Welcome back to the equine anatomy lectures. In the first set of lectures, I talked about the equine head, number of structures, and the clinical relevance of the structure. Then the last lecture, I talked about the equine neck. Today, we will continue on the same outlines that I pointed out last time. These are the outlines that I mentioned. I talked about the significance and how important the neck and the neck structures are. Muscles of the neck, I mentioned a number of them: Sternothyroideus, Transversalis, Cleidiomastoides, Cleidobrachialis, Sternohyoideus, all of these, trapezius, rhomboideus, splenius, etc. And then I finished last time by started talking about the cervical fascia. And I mentioned that we have two types of fascia, superficial and deep, and we started talking about them, and I said we're going to continue in this lecture. So we will go ahead and start with the cervical fascia and their structures. So we have two types of cervical fascia. We have superficial fascia and we have deep. Superficial and deep. And I mentioned earlier that the superficial cervical fascia is loose connective tissue that protects the superficial muscles of the neck as well as the jugular groove. So it's loose connective tissue that wraps around the muscles of the neck and also protects the jugular groove. That's very important. Now, what's the deep fascia? The deep cervical fascia is regular, dense connective tissue compared to the superficial. The superficial is loose. This one is regular and dense and strong. And it protects three important structures in the neck: carotid sheath, trachea, and esophagus. The deep fascia. The superficial fascia protects muscles and jugular groove, and deep fascia protects carotid sheath, trachea, and esophagus. And there's a very important thing about the clinical relevance and the clinical significance of the fascia, and that is they communicate with each other. They communicate with each other, which means that any infection in one of these structures can actually move to the other structures and even more toward the thoracic cavity, causing death of the animal. Let's see a couple of examples here. So this is a punctural wound in the neck area around the jugular groove and the proximal third of the jugular groove. Now you can see the digestive material coming out of that punctural wound, and this means that the esophagus was punctured at this point. The 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 clinicians or the practitioner's nightmare is for this infection to go all the way into other structures such as the trachea, the carotid sheath, and go down, descend to the thoracic cavity and to the lungs, causing pneumonia and death. This is pretty important sequelae for the disease, and that is why practitioners are extremely careful about these kinds of wounds, because they know that there is communication through the deep and the superficial fascia, which will lead to a devastating results or conclusions. This is another case of neck infection, and we can see that the pus coming out of this area. And the problem is that if that wound was not open, if this abscess was not opened and drained properly, then there is a very good chance that this abscess, if it was not contained, it can go through, again, through the cervical fascia, superficial and deep, all the way to the thoracic cavity, infects the heart and the lungs, and the end of the animal will be devastating. So that is very important. Now, so let's talk about the superficial fascia. The superficial fascia is basically loose connective tissue that wraps around the muscles. You can see it here between the muscles in yellow, all between the muscles, and also wraps around the jugular groove. These are the areas of the jugular groove. This is a cross section, by the way, uh, of the neck at the level of the fifth cervical vertebra, at the level of the fifth cervical vertebra. And the superficial fascia wraps around the jugular groove as well as the superficial muscles. So now let's talk about the jugular groove and why is it important and things like that. So this is basically the jugular groove. This is the jugular groove of the horse. And this area is of extreme clinical significance. First of all, it's the most common site for drawing blood in the horse. This is number one site to draw large quantities of blood in the horse, the jugular vein, which is located in the jugular groove. Very important. Another thing is this site, the jugular groove, which basically contains the jugular vein, is the site of choice for any equine veterinarian to place catheters in the equine patient when needed. You know, for fluids, for IV fluids, for IV injections and things like this. Um, you need to place the catheter in the jugular groove, and therefore you have to know what the jugular groove is. Let's go back to the basic anatomy of this area. This is a picture that shows it's number 10 here. It's number 10 that forms the medial border of the jugular groove. Still, the ventral border here is quite clear, the sternothyroideus, but we took the dorsal border, which is the omotransversalis and clydeomastoideus muscles. We took them out because this is a deeper dissection of the muscles of the neck. But we can see clearly the medial border of the jugular groove, and that is the omohyoideus muscle. So dorsally, omotransversalis and clydeomastoideus, ventrally sternothyroideus, medially omohyoideus, and laterally cranial half of the neck, skin only. Caudal half of the neck is cutaneous coli. It's as I mentioned earlier, this is the best site, or the site of choice, if you will, for venipuncture in the horse. But there are other sites that veterinarians or practitioners can utilize. And since we are talking about the head and the neck, let's continue on that. What are the other sites for venipuncture in the horse that are in the head, for example? We have a number of them. So these are sites that shows you this is the skull of the horse, and we can see here a number of veins that we can utilize for venipuncture. But for example, number one is the transverse facial vein right here. But this vein is basically utilized for smaller blood amounts, to collect very small amounts of blood, 1 or 2 mils, for quick testing and things like that, PCVs, things like that during quick examination. But if you want more blood quantities for CBC and campanule, things like that, you need to get with the to go with the jugular vein choice. It's better. Also, you have the buccal vein, and the deep facial vein also, 2 and 3. All of them are ventral to the facial crest right here. You've seen that facial crest in the very first lecture when I talked about the external features of the skull. So immediately ventral to the facial crest, we have the sinus, the transverse facial sinus, which basically contains this blood. This is very good. This is very good for small amounts of blood. So the transverse facial, deep facial, buccal, which basically forms the sinus. So these are alternative sites for venipuncture in the horse. There are other venipuncture sites. So we mentioned the transverse facial vein, ventral to the facial crest between the lateral and the medial canthus. Now, you have also the cephalic vein, which I mentioned earlier, that it's covered by the cutaneous coli. So you can do that on the between the radius and the ulna, medially, on the medial of the forelimb, basically. The cephalic vein between the radius and the ulna, you can see it. It's pretty large and easily accessible. Same thing with the saphenous vein. We'll talk about them when the saphenous, when we talk about the hind limb. It's also medially on the distal tibia, and also you can see it pretty clearly. It's as big as your thumb. Basically, the other one, we'll talk about it when we come to the thoracic cavity and the thoracic wall. It's called the superficial thoracic vein, spur vein, superficial thoracic vein, or spur vein. The transverse facial is basically utilized pretty commonly. This is how you draw blood from the transverse facial vein. Pretty accessible site, and again, for small amounts of blood. This is very important. Small amounts of blood. These are the cephalic vein on the left-hand side picture. You can see it between the radius and the ulna on the medial side of the forelimb, uh, on the arm basically, and then on the medial aspect of the distal tibia, you will see the saphenous vein. It's a huge vein, and you can utilize both the saphenous and the cephalic to draw blood, and sometimes even to place catheters. Um, uh, the facial artery or the mandibular artery on the since we're talking about the head and the neck, facial artery is, or the mandibular artery they call it, also is a good site, is a primary site to get pulse from. Also, you have the transverse facial artery. You can see how the clinician is putting his two fingers on the artery to basically also measure the pulse. That's a secondary one after the facial artery or the mandibular artery, which I showed you in the previous picture. So with this, I conclude the talk on the superficial fascia, which wraps around muscles and also around the jugular groove. And in that, we've talked about the borders of the jugular groove. Ventral border is the sternocephalicus, dorsal border omotransversalis and clidomastoides, medially omohyoides. Laterally, the first half is skin only, the caudal half is, or the cranial half is skin only, the caudal half is only cutaneous coli. So these are the borders for the jugular groove, and we also mentioned a number of other sites to get blood from, like the transverse facial vein, and also cephalic vein and saphenous vein, and also the superficial thoracic vein, which is the spur vein. And also we talked about the transverse facial artery and the mandibular artery or the facial artery itself as sites to measure pulse. So this is the end of the superficial fascia. Now we're going to go to the deep fascia. This is a picture again, a cross section of the neck, again about the level of the fifth or sixth cervical vertebra, and here we can see the deep fascia wrapping around the trachea, the esophagus, and also the carotid sheath. The trachea, the esophagus, and the carotid sheath. Three major structures. Three major structures. These are some of the components of the carotid sheath. We have the vagosympathetic trunk. Vagosympathetic trunk. We have the huge common carotid artery, and then recurrent laryngeal nerve, and I've talked about that when I talked about laryngeal hemiplegia in horses and how we fixed it with a surgery that's called the tieback or laryngeal prosthesis. We have the tracheal duct also, and we have the trachea, and these are the two thin muscles, the Sternohyoideus and the Sternothyroideus, which we cut during the modified fossils technique. So the carotid sheath contains a number of very important structures, such as the vagosympathetic trunk, vagus nerve, and the sympathetic innervation, the carotid artery, the recurrent laryngeal nerve, and then the tracheal duct or the thoracic duct. The omohyoides is not protecting the carotid or anything. It's a relatively a thin muscle that you know um, can be bypassed by a needle easily, as I mentioned here, because it's the medial border of the jugular groove right here. It's number 10. Recurrent laryngeal nerve, and we've seen laryngeal hemiplegia when the arytenoid cartilage is paralyzed. This is after the surgery, after the tie back. We've seen that, and we've talked about that earlier. Uh, Sometimes before endoscopy, clinicians used to have what's known as the slab test. So what they do is they put one hand on the larynx here, and they slap the horse over the shoulder here, and they feel if the recurrent laryngeal nerve is not injured, they will feel the the two arytenoids moving. But of course, if one of them is paralyzed, they will feel one that's moving and the other is not. And so that is a that's a like a test that was done pretty early before endoscopy. Uh, now most people, if not all of them, basically utilize endoscopy to diagnose laryngeal hemiplegia. And we've talked about how we need to fix laryngeal hemiplegia by placing a suture between the muscular process of the arytenoid cartilage and the caudal-most aspect of the cricoid cartilage dorsally. And when we pull the suture back, that's when the arytenoid basically opens up uh, to 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 open the trachea, and to open the larynx, so the air can go to the trachea easily without any blockages. The trachea is the second thing that I'm going to talk about, that is protected by the deep fascia. After we talked about the vagosympathetic trunk, we're going to be talking about the trachea, and then after that we're going to be talking about the esophagus. So now we're going to be talking about the trachea. First of all, this is the thyroid gland, number 10, and here, as I mentioned earlier, around it, which is number 5 in this case, this is the cranial deep lymphatic center. We have the middle deep lymphatic center, and we have the caudal deep lymphatic center. So this is the cranial deep cervical lymph center, cranial deep cervical lymph center, and it's around the thyroid gland, number 10. Transtracheal wash is basically a procedure that clinicians utilize to collect fluid from the respiratory system, from the trachea, bronchioles, and from the lungs, of course. And what you do is on the ventral aspect of the trachea, on the fifth to the sixth trachea rings level, you have the annular ligament between the two rings. You puncture that with a scalpel blade. Everything needs to be done in an aseptic technique. And then you insert a very long plastic tube all the way down, and you put some, inject some sterile saline there, and you collect it. So you inject the saline and collect. You do that a couple of times, and then you take the collective fluid and you take it to the laboratory for analysis to see if that fluid is infected or not. We call that Trans-Tracheal Wash. This is basically how the procedure is done. First, the area is being clipped and prepped surgically, and then with a scalpel blade, you open this area like a 1 centimeter incision in the annular ligament between the fourth and the sixth trachea rings. After that, you insert the plastic tube in the trachea all the way to the bronchioles, and then you start injecting liquid, which is, I mean, liquid as in, sterile saline, and then you start aspirating back what you injected. And here you aspirate, as you can see here, you aspirate, and this is what the clinicians collected. This fluid that they collected go to the laboratory for analysis, basically. This is basically transtracheal wash. Now, if this procedure is done through an endoscope, we call that bronchoalveolar lavage. But we have to utilize endoscopy, so we have to utilize the true and the false nostrils. We close the false nostril. We go into the true nostril ventrally in the common nasal meatus, go all the way to the trachea, insert the scope all the way to the end of the trachea, to the bronchioles, and then start injecting from the outside, injecting sterile saline and collecting that the same way we're doing here. But this is basically a cheaper procedure because you're not going to utilize an endoscope. The last procedure in the trachea, and that is the tracheotomy and tracheostomy. Tracheotomy and tracheostomy basically. Tracheotomy is an opening in the trachea to facilitate respiration. Tracheostomy is cutting a piece of two trachea rings and place a tracheotomy tube so the animal can breathe easily. Both of the procedures will help the animal breathe easily. However, the first procedure, which is tracheotomy, is an emergency procedure. This happens sometimes when horses are choking and they could not breathe. All what you need to do is just go in there between the two trachea rings and cut the annular ligament, shown here. Cut the annular ligament. Once you make the cut, that's it. You put your tracheotomy and the horse can breathe easily. This takes 5 minutes. The whole procedure takes 5 minutes. On the other hand, the tracheostomy is basically a complete surgical procedure that needs to be done in the surgery room and under aseptic technique and prep and clip surgically and everything. And then you cut an elliptical incision around one trachea ring and another elliptical incision around the other trachea ring. Again, part of the annular ligament will go, and this circle basically will become permanent, so the horse can breathe from it permanently. Now, this is done again on the ventral aspect of the trachea, and as shown in this picture here. And we have to understand that there are two very thin muscles, the Sternothyroideus and Sternohyoideus muscles, that needs to be separated so the trachea can appear easily to the surgeon. And he or she can cut the trachea rings and place the tracheotomy tube. So these are the two muscles that can be separate. Very thin sternothyroidus and sternohyoideus muscles. Again, they're shown here. Very thin sternohyoideus and sternothyroidus muscles. Again, at the level of the fourth to the sixth intertracheal rings, you cut elliptical incisions between them and you place your tracheotome. This is the tracheotomy tube. It has two parts. One is movable, the other one continues to be stable. You insert one side in the trachea and then you twist it. Once you twist it, it stabilizes the other one in the trachea. This is how it's done. You open at the fourth to the sixth or trachea rings level, and then you separate the two thin muscles, sternohyoideus, sternohyoideus muscles, and you place the tracheotome as seen in this picture. You place first the first one, stabilize it, and then put the movable part inside and twist it. Once you twist it, stabilize, becomes like this. It becomes like this, stable, and it doesn't move at all. And this is, again, this is a permanent procedure. So if there's a tumor, there's some sort of a lesion that's preventing the progressive lesion, if you will, that's preventing the horse from breathing freely, then definitely you will utilize tracheotomy. Uh, 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 now, if it, or tracheostomy, I'm sorry. Now, if it's an emergency procedure that needs to be done and the horse will recover from it and things like that, then that's a tracheotomy, like this one. So tracheotomy is an emergency procedure. Tracheostomy is done with a progressive disease, a tumor or a lesion that's preventing or will prevent the horse from breathing normally for a long period of time, or even sometimes all their lives. They're going to stay with this tracheotome or with this lesion, like shown in this picture. This is the site where you have a tracheostomy area. So tracheotomy, again, is an emergency procedure. Tracheostomy is a permanent procedure. Tracheotomy is emergency. Tracheostomy is permanent. That's I think that clears the difference between the two procedures. However, the two procedures are done both at the level of the 4 to the 6 tracheal rings. With tracheotomy, you only cut the annular ligament, only the annular ligament between the rings. In tracheostomy, you cut elliptical parts from two consecutive trachea rings, as well as the annular ligament. These are the two muscles that are separated, are sternohyoideus and sternothyroideus, very thin, located ventrally on the trachea, on the ventral aspect of the trachea. Now we finish the trachea. Next, we will be talking about the esophagus. The esophagus is the third part, or the third structure that is covered by the deep fascia. The first one was the carotid sheath, the second one was the trachea, and the third one is the esophagus. Next time we will be talking about the esophagus.